Everyone talks about ADHD in terms of attention, hyperactivity, or impulsivity. You'll hear dopamine mentioned, executive function, maybe even motivation. But there's one word you rarely hear when people talk about ADHD treatment, and that's sleep. And here's the kicker. Most ADHD treatment plans will fail, not because the medications are wrong or the diagnosis is off, but because nobody's addressed sleep. And that's what we're going to cover today. I'm Dr. Sanil Rege, psychiatrist and educator, and someone who works closely with sleep physicians. I've created an entire course on the neuropsychiatry of sleep. And let me tell you this, if you're treating ADHD and ignoring sleep, you're starting at the wrong end. In this video, I'll show you how sleep and ADHD are deeply connected, biologically, psychologically, and clinically, and how ignoring this connection can lead to non-response, misdiagnosis, and poor outcomes. So let's start off with the scale of the problem. 82.6% of people with ADHD have reported lifetime sleep problems. That's more than double the general population. Sleep disturbances in ADHD are not just about struggling to fall asleep. They include restless legs, sleep apnea, night terrors, and even signs that mimic narcolepsy. The odds of having one of these conditions range from 1.8 to over 14, depending on the condition. Yet, sleep is rarely assessed or managed first line. If we're not treating sleep, we're treating the wrong problem. So let's look at the ADHD and sleep loop. This is where things get really interesting. Sleep problems can cause ADHD-like symptoms like inattention, irritability, poor impulse control. And ADHD can cause sleep problems due to hyperactivity, cognitive hyperarousal, or medication effects. So what we're dealing with is a bidirectional loop. The less you sleep, the worse the ADHD symptoms get. And the worse the symptoms, the harder it is to sleep. Fixing only one side won't work. But not all sleep problems in ADHD are the same, and this is key. There are at least 4 sleep phenotypes that show up commonly. 1, delayed sleep phase syndrome. They can't fall asleep until 2 or 3 a.m. 2, restless legs and periodic limb movement disorder. This is often underdiagnosed but massively disruptive. 3rd, sleep disordered breathing, including snoring and sleep apnea. 4th, stimulant-related insomnia from rebound or mistimed doses. Each requires a different intervention, whether it's light therapy, melatonin, iron supplementation, or optimizing medications. What's important to remember, if you don't subtype the sleep issue, you're flying blind. So what's the neurobiological link between ADHD and sleep? ADHD and sleep share underlying brain circuits. This includes the frontostriatal system, which regulates attention and movement, the default mode network, which is overactive in ADHD and can often lead to ruminations at night. The patient that says, I can't fall asleep because my mind doesn't shut down. And circadian rhythm pathways, often delayed or blunted in ADHD. So we're not just talking about behavior, we're talking about biological rhythm disorders. So here's one way to think about it. ADHD is really a disorder of rhythm. Attention, emotion, and sleep all follow patterns. So what's the clinical impact? Here's what poor sleep looks like in practice. Children labeled as defiant, teens with poor academic performance, adults with burnout and low motivation. And here's the stat that should make every clinician pause. 26.6% of ADHD individuals sleep less than 6 hours a night. Compare that to 7.6% in the general population. That's a red flag. Treating ADHD without assessing sleep is like prescribing glasses without checking vision. So how do we approach sleep dysfunction in ADHD? First, we take a sleep history using the 3P model. 1, predisposing factors, genetics, temperament, baseline anxiety. 2, precipitating factors, stress, grief, lifestyle change. 3, perpetuating factors, screen use, late night routines, unhelpful beliefs. Then we go deeper. Sleep diaries, Epworth sleepiness scale, morningness, eveningness questionnaire, actigraphy if circadian disorders are suspected. We also screen for obstructive sleep apnea using stop bang and ask about restless legs. In kids, we might use the CSHQ or SDI. If you don't ask, you won't find it. Sleep should be part of every ADHD workup, not an afterthought. So once identified, what do we do about it? We have options: behavioral, pharmacological, and psychological. For example, for delayed sleep phase, we can use melatonin. 3 to 4 hours before desired bedtime. Dim lights in the evening and bright light therapy in the morning. For restless legs, check ferritin. Treat if less than 75 micrograms per liter. Sometimes iron supplements are all you need to improve both sleep and ADHD symptoms. If obstructive sleep apnea is suspected, refer for a sleep study. In kids, removing tonsils can improve ADHD symptoms dramatically. For stimulant rebound insomnia, try a small, short-acting evening dose or switch formulations. And don't forget behavioral strategies, consistent wake-sleep times, no screens before bed, bedroom as a sleep-only zone, and CBT-I. Though underused, is incredibly effective and even more so when tailored for ADHD. Good ADHD treatment means good sleep management. Let me give you a case. 35-year-old woman diagnosed with ADHD on stimulants, still struggling. Turns out she was going to bed at 2 a.m., waking up at 6, and had undiagnosed restless leg syndrome. Ferritin was 18. We adjusted her dose timing, added iron, used melatonin, and gave her a structured sleep routine. Within 3 weeks, her attention, mood, and energy improved. Sometimes the breakthrough isn't a new medication, it's better sleep. So let me summarize this for you. If you're managing ADHD and not looking at sleep, you're missing the foundation. ADHD is not just a disorder of focus, it's a disorder of rhythm. Attention, mood, arousal, and sleep all follow patterns, and if one is off, they're all off. Better sleep, better outcomes. If you found this helpful, share it with someone for whom it might make a difference. And check out the description below where I leave a link for the articles on the neuropsychiatry of sleep. For clinicians, we've got a full course on the neuropsychiatry of sleep at the Academy by PsychScene. This is where we cover the science that doesn't always make it into psychiatry training. And if this video made a difference to you, give us a like and subscribe to our channel to stay in touch with all our future releases. Thanks for watching. Look forward to seeing you in the next one. Until then, stay curious. Bye-bye.